Okay, in the last chapter, I'm going to lecture over our physical impairments, chapter 49. And let's go over our chapter objectives. Identify barriers for people with physical impairments. Describe the causes and age of onset of common physical impairments. List various physical conditions of people with physical impairments. Describe the clinical considerations for the treatment for people with physical impairments, and describe treatment modalities and adaptations for persons with physical impairments. Describe modifications that the dental hygienist may make when providing care to people with physical impairments. Describe conditions, causes, and incidents of various impairments. And lastly, perform a two-person wheelchair transfer. And just what is physical impairment? Well, physical impairment is defined as any physiological disorder or condition, cosmetic disfigurement, or anatomical loss affecting one or more of the following body systems: neurological, musculoskeletal, special sense organs, respiratory, including speech organs, cardiovascular, reproductive, digestive, genitourinary, hemic and lymphatic, skin, and endocrine. So physical impairment is recognized as a medical impairment because resulting from a disease, such as polio. Musculoskeletal conditions involving the joints, limbs, and associated muscles. We'll talk more about that in just a moment. Neurological conditions involving the central nervous system. Sensory impairments involving hearing, vision, or speech. What's the prevalence? Well, about 54 U.S. adults report difficulty walking, bending, reaching, and using fingers. I have problems with 2 of these, or 3 rather. 13% of adults report vision or having hearing difficulties. And in the old days, before 1960, people with physical impairments often lived institutionalized, and they were not mainstreamed. But the shift in thinking in the 1970s is for these people to live independently. Okay, so let's look at some of the barriers to healthcare access. There's financial barriers. Remember, cost is the primary obstacle for people with impairments. They just don't have the extra money because they live on subsidized incomes from Social Security and disability, unless they have lots of retirement money. Architectural barriers, and by the way, I'll just add to, even if people are on Medicare or Medicaid, there are several limitations that there are just some things that plan will not allow coverage for. We also have architectural barriers. These are physical barriers that all local, state, and federal facilities now are required to be barrier-free due to many different laws adopted over the years. There are also transportation barriers. Many individuals are forced to travel a great distance to find a facility where insurance is accepted or where they can be treated. They have inaccessible stations, such as the architectural barriers that I talked about earlier, and weather may figure into this as well, and cost may make transportation difficult if they do have to travel that long journey to get to where they need to go. And then there's attitudinal barriers. This results from not the individual with the special needs, but from another individual's misunderstanding, ignorance, or dismissal of physical impairments. Other areas, depression, lack of knowledge of available resources, and they may not realize the importance of a healthy mouth and social acceptance and not consider it a priority. Now let's talk about some different types of physical impairments that are a result of a certain condition. There can be inherited or genetic. That's not supposed to say generic, it's genetic. Muscular dystrophy, cystic fibrosis, and spinal muscular atrophy. Congenital, that means they're born with it. Spina bifida, traumatic birth resulting in cerebral palsy or hydrocephalus, abnormal or missing structures such as in cleft palate. Development, any physical impairment manifested before 22 years of age. Medical, polio, trauma, accident, autoimmune, rheumatoid arthritis, and degenerative sensory. Acquired is any physical impairment manifested after the patient is age 22. Medical trauma may lead to degenerative macular degeneration. Age-related, this is any physical impairment manifested after year 50. Medical trauma, autoimmune, or degenerative diseases such as Alzheimer's. How do we classify these impairments? Well, they're classified either by etiology, what causes them, how they started, whether they're genetic, congenital, developmental, acquired, or as we saw in the age-associated. So, what's the job of the dental hygienist in dealing with physically impaired patients? Well, you want to give good oral hygiene instructions, but you need to be given it geared toward the patient's ability. Don't try to teach them something they absolutely physically cannot do. Do not assume that a patient with a physical impairment also has a cognitive impairment. Remember, these patients are hopefully fine, they just can't communicate properly. Teaching the patient, employ the tell, show, do approach to simplify instructions. Tell them how to do it, show them how to do it, and let them do it. Modify your recommendations for their special needs. They may have dexterity complications, such as I am starting to have because I have trouble holding onto floss. You need to suggest modifications for folding the toothbrush and flosser, and/or teach the caregiver, the person who's actually physically able to care to them. And I have seen specially designed brushes that will attach to the side of a sink so a paraplegic can use it to brush his or her teeth. So these are the modifications I'm talking about. Okay, so this is a sequence of how you will approach this patient. Before the appointment, if the patient has seizures, record on chart about the frequency of seizures and the medications they're on. Determine beforehand if medications have been taken correctly. Did they take them as they should? Know any trigger factors. Be prepared to handle a seizure. And should you be using a rubber dam with a rubber dam clamp, tie a piece of floss to it so you can easily retrieve it should the patient have a seizure. Before the appointment, you also want to be aware and understand the patient's abilities. People with physical impairments have varying degrees of movement and posture. Now remember, as we get older, we may move slower, so we'll get there, but it may take us longer. Will the patient be bringing a caregiver? Allow enough space in the operatory to accommodate all those who will be there. Does the patient have sensory issues? Does loud noise bother them? Does light bother them? You may want to turn the patient's hearing aids off, or if light bothers them, you may want to slightly dim the room. Is the patient hearing impaired? If they read lips, speak in a normal tone and cadence and face them. And don't wear a mask. Use a face shield if necessary. But if they sign, ask them to bring an interpreter to the appointment, unless you know sign language. Is the patient visually impaired? Determine the level of assistance the patient will need to move about the office. Rely on the patient's other senses to establish trust. Face the patient when you speak to them, and again, speak directly to them. You can have a mask on at this time, but speak with enunciation and make them aware of all the procedures beforehand. Is that patient able to communicate? Ask if an interpreter will be needed. The patient may need to use an adaptive device, such as a board with letters on it, or some other device, which is probably more likely to be computer generated now. They may need to use that to help them. Does the patient have visual limitations? Again, the same as you would with the one that is visually impaired. Speak to the patient as you would anyone else. Do not speak to the caregiver until the patient does not respond. Be consistent. Listen actively when communication is slow. May you have to stop and listen carefully. Schedule short appointments. Now, what about during the appointment? Move the patient in their wheelchair if it's properly designed. Some patients can lean back in their wheelchairs, or some may need to be transferred to the dental chair. You want to keep a clear path on the way to the chair. Keep instruments and equipment out of the way. Ask if they need extra padding or pillows. If they have dysarthria, this means they have trouble with speech and mastication. Be patient. Remember that many people have normal intelligence. Consult the caregiver if you have trouble understanding the patient's speech. And if you have a patient who stutters, let them work through it. Be very patient, and they'll get there. Primitive reflexes. In other words, don't try to answer stuff for the stuttering patient. Don't try to anticipate what they're saying. Let them tell you. Primitive reflexes are reflexes when the head is moved or the patient is startled. These type of reflexes are asymmetric tonic neck reflex, tonic labyrinth reflex, startling reflex, which we've all probably experienced, and minimize the number of distractions in the setting. Tremors. Uncontrollable tremors may require a steady hand. You may need to help hold their elbow to get them safely to the chair, but you ask before you do it. Special attention needs to be paid to your instruments. Remember, if the patient jerks suddenly, they don't have any control over that, so you're going to have to control whatever you have in your hand. Drooling, hypotonia, it's loss of muscle tone, contributes to drooling. Manage the oral secretions with evacuation techniques. You may want to avoid the loose tissues with the suction, the high speed of suction, especially because it will catch the tissue and damage it. But it's also helpful to have someone helping you with high speed evacuation if you need it. Use care when positioning the dental chair. Just don't assume that these people can automatically go to the place where you want them to go. You ask them, do you have any problems leaning back? Do I need to go slowly? People with musculoskeletal disorders just simply cannot be forced into some positions. It's uncomfortable or painful for them. Don't put the patient in the totally supine position. You may want to set them up at a 45-degree angle or more, depending on what they can tolerate. Use padding to help the patient. Ulcers of the skin are common. Have the patient shift around and move to be more comfortable frequently, and provide frequent breaks for patients that are able to walk. It may be difficult for the patient to remain still for a long time. And also remember, if they are on some certain medications such as diuretics, they may need several bathroom breaks. Use a catheter for people with no bowel or bladder control. Of course, this will always already be done for you. You don't have to put in the catheter, but you'll be aware and help the patient maintain that the bag remains below the level of a chair. Does this mean you might have to hold on to that bag or move it in some way? Yes, it does. Utilize an assistant. Uncontrolled reflexes, tremors, and seizures can be minimized with the help of an assistant. At the end of the appointment, what will you do? Well, whatever is necessary to get the patient out of the area safely. You want to watch the patient closely, be alert for postural hypotension, establish short recare intervals, use critical thinking to create aids for home care, get constructive with this. Include the caregiver in all home care instructions. Consider the uses of alternative treatments. And I'll mention some of those briefly. We may want to have them treated in a different facility. I know the OHC clinic, the dental clinic on UAMS, gets calls from all over the state about, could you handle this patient? Because we don't have the facilities to do that. Okay, so these are some of the alternative positions. You may want to sit behind the patient or stand when treating them in a wheelchair. Or many times when I went to the nursing home that I was practically in bed with the patient trying to treat them. You want to show them properly how to brush their teeth at an angle along the gum line and brush gently with a circular motion or short strokes. If the patient is able to do this, show them. If the caregiver is able to do this, show them. And if it's necessary to do a transfer from a wheelchair to a dental chair, remember that that wheelchair is part of the patient. And also a cane or any kind of walking device is necessary for a patient, and you should put it in a respectable part. If you carried it out of the room, the patient might get nervous. Determine the patient's needs. Prepare the dental operatory. Prepare the wheelchair. Lock it down. Perform the two-person transfer, and that's talked about on page 777 as well as on the picture at the very first part of this chapter. Position the patient after the transfer from the dental chair to the wheelchair, and don't assume that just because they're in a wheelchair that they need you to drive them. Some patients actually prefer to drive themselves, so don't assume anything. When they're in a wheelchair, you need to get on a level where you're looking right in their eyes. So when you communicate, they can easily see you. Okay, so we can have conditions, inherited and genetic conditions. Those are already talked about this. We can have muscular dystrophy, The most common form is Duchenne's and primarily affects boys. The onset is between age 3 to 5. Then there's also fascioscapulohumeral. This usually begins in the teenage years, causing weakness in the face, arm, leg, and shoulder muscles. So you can imagine they might have trouble transferring on their own. Myotonic, which is the most common adult form, causes prolonged muscle spasms, is associated with cataracts, cardiac abnormalities, and endocrine disturbances. So this might require a physician consult. You can have oral facial characteristics. Look at the figure 49-6. It shows you a few of those. So not at a table, not at figure 49-6, but at the picture on the table 49.6, oral facial characteristics of muscular dystrophy. And you see there are many condyles can be inclined backwards, delayed tooth movement, and enlarged tongue, and so on and so on. But there's many conditions that are involved. This is that table that I was just referencing under table 49.6, and I'll give you just a moment to look over it. Continuing with conditions, we can have congenital conditions such as spina bifida. This might be myelomeningocele, hydrocephalus, and clinical considerations. So let's talk about these for just a moment. Spina bifida is a birth defect in which backbone and spinal canal do not fuse before birth. It's also known as a myelomeningocele. Hydrocephalus is an abnormal accumulation of cerebrospinal fluid in the ventricles of the brain that may cause enlargement. Clinical considerations of these conditions: schedule short appointments to prevent stress, add some padding to the dental chair, change the patient's position during the appointment, and you may want to use a bite block, such as a rubber bite block. Carrying on with more conditions, there are also developmental and acquired conditions. Traumatic brain injury, this can happen to an adult or child. Spinal cord injury, again, that could happen to anybody due to an accident. Upper motor neurons could be affected. Lower motor neurons may be affected. Patient could be paralyzed or maybe quadriplegic. That means it involves all their limbs, or paraplegic involves the lungs or the not lungs, but the legs or the arms. So in summary, lack of access to dental care is a critical problem for people with physical impairments. Maintaining good oral health is particularly important for good overall health of patients with physical impairments. If they cannot maintain the oral cavity, bacteria can go anywhere. Successful provision of oral hygiene care for people with physical impairments requires a basic general knowledge of conditions resulting in disease of impairment, but mostly I think it involves an open mind and letting the patient help guide you or the caregiver. And here are our which I showed a minute ago, and then also Impairments can be grouped together by their similar manifestations, the functional status. There are 5 areas of function that can be affected: communication, speech or hearing, movement, uh, how well can they move and are they able to get in that position, mental ability, how well can they understand what you would like for them to know, medical health, or even the prescriptions that they take for the medical health may affect their dental health, causing xerostomia. Sensory perception, such if you ask me to, or if I ask you to help me tie my gown together, it's not because I'm an idiot, it's because I can't feel my fingers. And don't ask me to check out a quad, because unless it's just a simple A patient, because I can see that, but I can't feel it. Okay, and if I look like at you, like I didn't understand you, treat me like you would a patient and repeat yourself clearly. Okay, that's it.